Bismillah ar-Rahman ar-Rahim. Today we'll start on some talk on modern anesthesia. It may not be a clinical, but it may be very important for those who are especially going for the senior positions, administrative sides, and plus this one, the senior consultants. The bad thing or good thing is that this topic is not available anywhere and the top any literature or any book. I just created it, but of course with the help of AI, I use Claude and the Copilot. They created even the topic, even say help me out, even the what you call it slides. So let's start with this one. My lecture outline will be high reliability system. First, we have to understand what is this high reliability system, HRS, technology in modern anesthesia, evidence-based guidelines, human factor and crisis management, military medicine perspective like King Fahad Armed Forces Hospital. What are the constraints? What are the available? Like we have special, consideration like we may deal with end up with the trauma or some other scenarios. And then we'll do some case scenario if there is a time. So why high reliability matters in anesthesia? Because patients are getting more and more complex, more sicker. You may be noticed already 10 years back or 15 years back, patients were not so complicated. Coming a patient, or maybe I am the only noticing that patients are coming more and more complex day by day, and they are more sick, and they are more old ages. It's not only here, everywhere, especially in the West, where those who are getting patients are old and having more and more comorbidities. And it has rising safety expectations. People read on the net, people read every day on the Google, and they expect more and more from us. And there is a rapid advancement in technologies. Like every day, 3 or 4 years back, there was no concept of add-on this artificial intelligence, but now it's becoming part of all and by and large medicine, and especially there is a special field for this medicine. And at the end, it's a human factor, but still human factor is, okay, what are the high probability systems we have to understand? Just briefly about this one. HRS, preoccupation with the failures. Actively search for potential failure before they cause harm. Treat near misses as learning event. This is first part of this one. Preoccupation, these are 5 parts of this HRS system, or 5 types you can say, reliability systems. Preoccupation with the failures. Reluctance to the simplify. Before we were, 5 years, 10 years, even 15 years back, we wanted the most simplest thing. Now they are saying, no, it's wrong. We have to go for the complex thing. We have to sort it out, the complexity of the nature of this one. Resist oversimplifies explanation, embrace complexity, and in no sense, in adverse event analysis. Sensitivity to operations. Frontline staff, especially those our registrar, senior registrar, they are facing, they should aware of the situation in advance before things escalate. Commitment to resilience. Resilience means if someone is hitting me, I will say, okay, either hit or I will hit you back. This is the actual meaning of resilience. So we have to be very resilient. In this one, system are designed to absorb disruption and recover quickly without patient harm. Like suppose we are in a OR and there is a fire and the cases are going on. We should know how to manage this one, fire, and deal with the immediate. And once they settle everything, we should start. We are doing resumption. We are resuming immediately. It's over. So this is called system resilience. It doesn't mean that something happened. Oh no, we will not do this one. We are not in a mode this one. And deference to expertise. This is what I used to say always. Those who knows better physiology, better pathology, they are senior than me. even if they are 15-year, 20-year junior to me in by age, by experience. But if they know better than me, they are more better, to explain or better to lead even. Want to go back? There are three pillars of anesthesia reliability. In this system, there are three systems. Technology, what we can do with the technology. Guideline, what we should do. Guideline tell us what we should do. And human factor, how we will behave. These are three pillars of this HRS system in anesthesia. And with the mindset, zero harm mindset, borrowed from aviation and nuclear industries. I just want to emphasize on this one. HRS system is designed and being implemented by the nuclear and the aviation industries. We are always the third. Anesthesia is the always third specialty who is adopting, because anesthesia, there is no gray, either patient alive or dead. Unfortunately, this is a part of complex. I don't want to give detail. We all know that patient is alive or patient is dead. There is, like surgeon, if there is a small puncture, like I see there is a one tonsillectomy coming day and night every time. This is the fifth time she is come. But patient is still alive. But in anesthesia, there is no something like you gone, okay, we can manage tomorrow, or we can come tomorrow, this one. Or we can call the surgeon, flan, we can call and he can manage this one. First step is the first pillar is the technology in modern anesthesia. It includes monitoring, evaluation, artificial intelligence, ultrasound, and closed loop system. These are four parts of this technology in anesthesia. Smart infusion system, like target control infusion, pumps and drugs, liberally enabled smart pumps reduce dosing error significantly. They are smart. Now the target control infusion sets are automated documentation. It reduces the burden, plus it's reduce the error, plus is the faking, this one. First of all, ultrasound. Ultrasound is like our stethoscope. Before we used to have this one stethoscope in our every doctor putting on this one. This was a symbol of doctor. Now ultrasound is they are saying this is our new stethoscope. And in ultrasound enable this one facial plan block, like a erector spinae, tap block, pectoral nerve block, like quadratus lumborum block. These blocks should, by a lot, every anesthetist should practice, should know. There is no option for this one. These are called facial, 5 blocks are facial blocks. I can include even the femoral nerve and the popliteal nerve, this one, but these is 5, up till now guidelines are making it essential that these 5 essential blocks, and every anesthetist don't have the excuse to whether. Vascular X standard of care. Like in US or Canada, I know for a long time, if you put the CVP line without ultrasound and you by mistake to puncture the arterial line, you are liable for penalty. Because you have the system, you didn't use it. There is no excuse that you are expert. They don't believe on this one. So if we have in our department ultrasound, there is no excuse that you put or I put the CVP line without ultrasound guided. Arterial line, by and large, same in this one. Now the more important thing is focus in daily. Focus, this one, point of care ultrasound in daily practice. Lung sliding, like gastric volume, cardiac function, inferior vena cava, assessment are now accessible bedside skills. So this should be practiced even in the recovery room. Next step is the quantitative neuromuscular blocking monitoring. It's re-emerging emphasis on this one, quantitative blocking, because once the SUGAMED exam, even I do have, before reading this one, I do have concept that it's okay, patient is fully reversed backward. And even 100% I was not monitoring this one. But after this one, they found even 40% up to people still have this one and partial residual paralysis in the recovery room. they found in the analysis this one, and they are saying clinically significant residual paralysis less than 0.09 is found in 30 to 40% of patients extubated without quantitative monitoring. The bad thing with this government axis is we were very strong that believe that it's a very quick reverse and everything is okay. But problem is it's short acting as compared to the neostreptomine and glyco. And if there is a residual, it can affect this one in the recovery room. So we have to monitor this one. Quantitative TOF new standard, accelerometrography, electromyography devices like a Twitch view provide objective real-time train of 4 ratios. Extubate only at T of F at 0.9. Sugammadex reverse deep block rapidly. Quantitative conversion before extubation is mandatory. So what artificial intelligence and predictive analysis do? Hypotension predictive, this is very common now. It's a machine learning algorithm. Machine learning algorithm are mathematical procedures and sets of rules that allow a computer to identify pattern in data and make prediction or decision without being explicit programmed for every scenario. So machine learning algorithm analyze arterial wave to predict mean arterial pressure will be less than 65 millimeter of mercury up to 15 minutes in advance, enabling proactive management. Smart alarms, reducing alarm fatigue, because sometimes the alarms are fake and they are not, and we even start ignoring, and unfortunately it can happen that we think it's a false alarm, and it's a real alarm, this one. AI-driven alarm system cut non-actionable ICU alert by more than 50% using contextual pattern recognition instead of simple threshold. Or data integration platform. Just like unified, this is called unified data from electronic health record, like labs monitor into single dashboard for real-time analytic and decision support. Like what it will do is it will immediately take data from the pharmacy, from the previous record, from the previous surgery, from everything, and give you data. Oh, this patient can have this and this concern in the recovery room, so be alert for this one. And the one more thing is coming is new feature is the opioid respiratory depression alert. Multi-sensor capnography with the saturation detect early opioid respiratory depression alert and can trigger automated medication lockout. It will automatically lock out for further even the duration of. Okay. Okay. It's a frees cognitive bandwidth for higher order tasks. Still require vigilant physician oversight. Emerging point in this one is the closed loop vasopressor system. We give phenylephrine, norepinephrine, but it will automatically detect and reduce the dosage according to this one. Not like we are giving, and at then once blood pressure is 200/30, we start reducing this one. In advance, it will start doing this one. The first step was the technology. It's a just brief touch of this one. The second, our pillar was the evidence-based guideline. What was the actually changed our practice from last 3 years? WHO surgical safety checklist. Mandatory pre-induction sign-in, sign-out steps proven to reduce surgical mortality globally. This is, and they are saying up to 40% of the incidence has been reduced with this one. I still remember in one of, maybe those who are Pakistani know, Sheikhupura is a hospital 2 years back. They operated on the person, 2 patients came with the same name, with same father name. And they operated instead of eye on the leg, and the leg, the person coming for leg, they operated on eye, and they keep on shouting. And though both surgeons are up till now, they are behind the bar after. So this is a mandatory step. Don't take it as a simple ASA monitoring standard. Continuous saturation, end-tidal CO2, ECG, NIBP, and temperature monitoring are non-negotiable requirements. Temperature monitoring, I just want to insist on this one. Now come to the third point is the institutional protocol and pathways. We can change our SOPs about if we see any guideline that is not suited to our environment, yes, we can change with the consensus. But everybody should have follow the same pattern, not like one person is doing this one and the other person is oh, sorry, was no. Okay, regional anesthesia and pain guideline, they are very strong endorsement of facial plan block for thoracic, breast, abdominal, and pelvic surgery. Multimodal analgesia is default, like paracetamol, non-steroid anti-inflammatory drug, ketamine, dexmedetomidine, and IV lidocaine infusions. They are mandatory. Opioid sparing pathway, reduce postoperative nausea, ILS, respiratory depression, and length of stay. More and more guidelines are coming just to reduce the opioid dosage because in West the people they have problem for the addiction of this one. People once they have seen patient got one fentanyl and he's carving for another kind in his life. In a few couple of months after this, he want to become an addict. I mean, like that is so new guideline on neuromodulation, spinal and stimulation for chronic post-operative pain. Shift in clinical thinking from should I block to which block is the best for this surgery. This is very crucial point. Instead of say I block or no, but no. Now I say which block is better for this surgery. Quantitative monitoring is required. Subjective, tactile, visual, train of 4 assessment is insufficient. Train of 4 more than 9 must be confirmed before extubation in every case. So Sugammadex preferred over neostigmine for reversal of moderate to deep block. Residual paralysis is defined as preventable complication. It must be measured, not assumed. Twitch view and other portable accelerometrograph make bedside quantitative monitoring accessible. Okay, pre-operative fasting, early enhanced recovery after surgery, ERAS. Fasting is the clear fluid permitted up to 2 hours pre-induction time. Carbohydrate, this is, I mean, they are emphasizing on this, especially in the diabetic patient and children patient, because they feel hungry and they are hypoglycemic and they are panicking. That will create a problem in the recovery room. Suppose they are getting late, it's pressure on the surgeon, pressure on the anesthesia and other OR stuff. And they have seen this reduced insulin resistance and patient anxiety, solid food up to 6 hours, fatty or protein food up to 8 hours. Some people always take 6 hours as a deadline. No, patient is obese, diabetic, comorbidity, any comorbidity, and any factor of delaying the stomach, it's 8-hour fasting time, not 6 hours. ERASA pathway alignment, not isolated guideline. Okay, preoperative medicine, updated like pulmonary scoring for thoracic surgery. We must have the scoring system for thoracic surgery. Fertility scoring, functional capacity assessment, it should be in the prehabilitation exercise, nutrition, smoking. This is part of some surgical team hour. ERASA pathway now standard across colorectal, ortho, and cardiac surgery. Goal is optimize the patient, not just the operation. Like I just add this picture as a frailty scale from 1 to 9. 1 is very active fit and the 9 is the terminal patient. Third factor is the human factor. Our crisis is source management. It is most under-taught dimension of safety anesthesia. Why human factor matter more than the technology? Most error are human, not technical. Up to 70 to 80% of preoperative adverse events involve communication failure, cognitive error, or situational awareness. I read one article headline. It was saying they did the assessment and found this one. They found that technically everybody was skilled, Everything was okay. Everything was available. Only problem happen is closed loop communication, no communication, I mean, late communication, or there was a even, as something like it could be a thing which should done earlier. It should is acting late. Okay, cognitive load in OR. OR is high noise, high interruption environment. Cognitive capacity is finite. Finite means it's limited. It's not unfinite. System must protect it. I mean, checklist and cognitive aid. WHO checklist alone reduce the surgical mortality. Structured cognitive aid prevent fixation error in crisis. Team communication is a trainable. CRM skill, closed loop communication, role clarity, assertive can be taught, practiced, and measured. They are saying like we should have the how we will activate this one massive transfusion protocol. It should be designed. Everybody should know its role. Everybody should know who will call, who will say, will end the call. Like I'm just giving the example. Everybody should have his assertive role, and no need to tell, okay, you do this one, I will do this one. No, you are not good. No, there is no time. This one, everybody, like in CPR, we are doing this one, and it has to be done like mock training drill every day, every month, every week, or every year, according to the requirement of this one. Like this one surgical checklist, this was which I talked before. It's very simple and clear. Problem is it should be applied like this one. Then it's written difficult airway. I wrote this one, yes, just couple of days before in the room 7, and I informed everyone there's a patient have twicely difficult intubation, 52 BMI, coming for this sleeve gastrectomy. So just give me time. So I will maybe an intubation. I prepare everything, even bougie to write CMAC and everything. I asked even Dr. Mafik to stay with me, beside me. But the nursing staff, what they were doing wrapping on the this one. It was for more than to save the time wrapping on the what you call on the legs to making the position. I said, for God's sake, if the patient will aspirate, it's of no use this surgery. She is a young 33-year-old. So give priority, help me a lot. On the other hand, I know one staff, I stuck in room 1, and once she noticed that I'm stuck, she said, you need help. I said, okay, yes, give me one more time, then you can call for the help. And she helped me, she left everything. I think I'll proudly say, although I have a lot of conflict with that lady, but Edna is the best one at that time I found, and up till now, in more than 2-3 years, I found, and still remember that one, how she helped me, even she helped me how to look like this one. This is sort of environment we need. Forget what we don't like each other or no. That's it. This time we should know our role, which is more priority. Patient life is more a priority for us. So we should already have, a design for like our brain training should be designed like this. That crisis resource management. What are the core principles of this one? Closed loop communication. Sender, like I suppose if I'll call to the blood bank, I need massive transfusion. He will receiver confirm receipt. Okay, you and this time we got a message. Your name is Dr. Akhtar Qureshi, and we are activating. This is sender acknowledge it. Okay, yes, this is okay, true. Eliminate assumption error in high stress moments. Role clarity in leadership. Explicit role designation before induction. Leader call out, decision, team member execute and feedback. Anticipation and planning. Mental rehearsal of what if. Like in recovery room, if we used to do this one, okay, if we fail, what if she go into hypotension? What is our planning before the case? Drugs, airway cart, and defibrillator ready before induction. And debriefing culture is very important. There are 2 types of debriefing. Hot debrief within 2-3 minutes. So we should have the exact what scenario, because after 1 hour, 2 hour, the story starts changing. So it's not that. So this is called hot debrief. and formal cold debrief after critical event drive continuous team learning. So these are the core principles of crisis resource management. Okay, fatigue, burnout, and decision quality. Fatigue impaired judgment equivalent to 0.08% of blood alcohol level, yet is normalized in medicine. High reliability system protect clinician, structured handover, duty limits, rest cycle. Decision quality degrade under fatigue. And importance of psychological safety, speak up culture, that's very crucial, require no fear of hierarchy. Institutional duty to protect cognitive resources like staffing, scheduling, and wellness program. Okay, this was one case in which I was talking about just want to skip this one. Operator focused on the grade 3, failed to call help. This was the case in which I just talked before that they found that it was not the skill of the physician, it was the communication gap and this other problem. Fixation error, operator focused on grade 3, failed to call for help despite 2 failed attempts. Poor communication, member noticed desaturation. The junior resident, he noticed that the patient desaturating but were reluctant to speak up due to perceived hierarchy, delayed escalation, cannot intubate, cannot oxygenate scenario reached before surgical air was called. Root cause, skill was adequate. CRM failure lead to harm. Communication, not technique, was the decisive factor. Lesson is, any team member may declare an airway emergency, not either is a junior or is a senior, it doesn't make a closed loop communication save lives. In military medicine, King Fahad, high reliable, we are working in a high reliability under real world constraints. Like in King Fahad, armed forces, can anyone tell me the difference between university working, I work in university, those from university, what is the difference if we are practice here and there? Like just because of the short time I was just about to explain, what is happening is in university you can like give you the example, you can give max sulfate infusion, you can give intrathecal max sulfate, still under trial, and but you can use. But in armed forces hospital, like this institution, you cannot use anything which is not well proven, which is not guideline. We follow strictly the guidelines. That's a difference between practice with this one. This is, I realized over just high reliability under constant field anesthesia, like we are supposed to cover even the field, like in case of crisis. Of course, the resources are limited, but we have to expect same zero harm standard for even the resources are limited. Damage control resuscitation, permissive hypotension, like we must know the damage control resuscitation program, permissive hypotension, balanced product, transfusion 111, rapid sequence induction protocol for trauma. This is high, like for military point of view, I make this slide for this one. Standardize, memorize, and drill. They are saying we have to build the muscles, practicing sometimes because at the mental block, time of mental block, muscles also help you to do what you are doing in normal routine. Robust protocol, repeatability. Whatever we do in protocol, it should be repeatable and it should come up the same positive outcome. Ketamine, okay. Simulation and military preparedness, regular crisis drill. I just go point because we are getting late. Team coordination under stress, muscle memory for critical task, equipment familiarization. We should know all the equipment. We should practice, even make it. If there is no case coming like malignant hyperpyrexia, but we should do a drill type of this one that everybody should know this protocol. And transportation, like in military, we are this one. Transport and critical care handover. Transport is high risk period, even in our OR to ICU. Limited monitoring, confined space, vibration, access controls, constant structured handover protocol like SABAR or ISBAR. We are using SBAR at every transition of care. Portable monitoring, compact pulse oximeter, capnography, and portable ventilator are standard. Human factor in aeromedical evacuation, like noise, hypoxia at high altitude, team communication, safe handover, explicit verbal plan, documentation, medication, and confirmed IV access. Just few more moments. I just want to make it short. This one. Intraoperative hypotension in elderly high-risk patients. 78-year-old female, male or female, 35 ejection fraction, urgent hip fracture, mean arterial pressure dropped to 58 in 20-minute over-induction. So how would technology applied? Focus, confirm low cardiac output, okay? HPI predicted event 12 minutes prior, goal-directed therapy we have to start, protocol activated. Human factor, closed loop communication, perfusionist called out, surgeon notified, vasopressors treated by protocol. Outcome, mean arterial pressure restored in 4 minutes, early detection, plus team communication, plus protocol-driven response. Actually, this was something like on a model, not, I mean, this case is not from the failed extubation. Same like we can check in the, they found in the recovery room that it was not reversed well. What should change tomorrow? Use quantitative neuromuscular monitoring in every case. Never extubate on assumption. Adopt ultrasound as a core skill, not as an option. Focus is now standard of care. I mean, I used to call it focus, but I don't know, it's wrong, or maybe Tarif can tell me. Point of care ultrasound, I mean, is now standard of care. Integrated ERS and multimodal analgesia consistently, reduce opioid burden systematically. Improve human factor, practice closed communication, checklist, train CRM. Train CRM means we do the, I mean, like a mock, and we have to train accordingly. Move toward data-driven, predictive, high reliability anesthesia system at King Fahad Armed Forces Hospital. Takeaway is the improve outcome, high reliability principle, reduce error, near miss, and preventable harm across all risk level. Technology enhance, not replace. Technology only artificial intelligence, advanced monitoring and closed loop system, it will enhance you, but it will not replace the anesthetic clinical judgment. Guideline reduce variability. Adherence to the neuromuscular blocking agent like regional anesthesia, ES, and fasting guideline. Practice gap systematically. Close practice, I mean, gap systematically. Human factors, communication, CRM, fatigue management, and psychological safety are trainable as technical skill. Continuous improvement is data simulation, debriefing, reporting, and culture drive sustained reliability over time. Future direction in anesthesia, AI and machine learning integration. From prediction to closed loop automation, AI will manage drug dosing, fluid titration, and alarm prioritization. Predictive and personalized anesthesia, genomic and virality data, and wearable. Even wearable mean like even as people are wearing Apple Watch, they found that this is also a useful item to integrate in that system. Individual pre-op optimization, individualized pre-op optimization and drug selection. Continue quality improvement. National database and real-time dashboard will benchmark outcome, identify practice gap automatically. Thank you. I know there are a lot of improvement in this one, need further enhancement, but I tried to, I mean, summarize in a way what is our future, what we are doing, where we are lacking, and what are the factors we can do improvement in this one. If anything is not clear, I'm ready to, but I cannot answer. I mean, this is so vast. If you ask me question, very difficult, but I'll try to explain anything whatever. Thank you. Thank you. Thank you. Jazakallah khair.